as early March, we made a command decision, like the rest of the country, to voluntarily shut down our what we call elective surgery. And right, we could debate hours on what does elective surgery mean. I'm an orthopedic surgeon and a reconstructive surgeon. So the person with knee arthritis or hip arthritis or low back pain that needs a fusion, is that elective? Well, it's an ongoing surgical need of a patient to improve quality of life. That's what we do as surgeons. So let me come back to center about what the University of Pennsylvania did as being an evolved one of the hot spots. Obviously, look to the north, to New York, and our colleagues had close communication and was sort of trying to cheerlead Fabrizio Michelozzi, one of our preeminent American surgical leaders, in terms of what he was doing at Weill Cornell in New York City. And we all learned from each other, and we had a rapid learning curve. That being said, I'm a big believer in the structure of and chain of command. And so our CEO here, Kevin Mahoney, and our Dean, Larry Jameson, felt not only a responsibility to our workforce, but a responsibility to care for patients safely. As everybody knows, we had ongoing needs in evolving cancer care, in all sorts of trauma. People still had car accidents, they still had broken bones, they still had mutilating extremity injuries, they fell off their motorcycles. So in terms of my own department, I was the gatekeeper, if you will, approving literally every case that was performed during the shutdown, during the ramp down. My faculty would email me. I have a patient that has a hip fracture from the outside. He or she is 70 or 80 years old. They want to transfer. Okay, we did that. We had available testing to make sure that we at least had the appropriate PPE and screening for patients. And so our trauma service was busy. I personally was busy with patients that, quote unquote, couldn't wait, people that were in staged aspects of their reconstructive surgery that would need to be done, need to be cared for, or else not caring for them in a timely fashion would compromise their care. So primary hips, as we call them, primary knee replacements, things like that, those patients were put on hold and rescheduled. And every surgeon in my department, actually every physician and surgeon, the medical service, the surgical service at Penn Medicine, we were all in this together. I think I would say collectively, and this goes for all my colleagues across the country, we've collectively never worked harder not doing surgery. We grew enormous knowledge in telemedicine that many of us have said, at least around the United States, this is going to be sustaining. Telemedicine is here to stay. The other thing strategically that Penn has done and done well is to be able to discharge patients and COVID care at home, which was a huge benefit to basically not overwhelming the health system. This home care delivery and monitoring of patients with digital technology. Kevin Volpe and David Ash, who work in our Center for Healthcare Innovation, have been very active. Roy Rosen, who used to work for Intuit, who's our Chief Innovation Officer. All of these strategies actually using technology to not only monitor what's going on inside our health system, but the patients that have been discharged and safely discharged to home with either ongoing home oxygen needs or recovery from COVID. We were not overwhelmed. Certainly our system ramped up and created several COVID ICUs, negative pressure. Again, we mimicked what went on in the country, but with a team spirit. The acronym, Together Everyone Achieves More, was really heartfelt. So coming back to myself, I don't think I ever worked harder, but not in the operating room, although I did operate, and of course that was a great joy and a need for patients. March 27th at 5 p.m., I convened with the chair of surgery here at Penn Medicine, Ron DiMatteo, our CEO of the nation's oldest hospital, Teresa Larrabee, who used to work up in New York City at Columbia. Pennsylvania Hospital is one of our 3 downtown hospitals that was founded by Benjamin Rush and Benjamin Franklin. and I convened a phone call with our anesthesia colleagues, nursing, other specialists such as otolaryngology, plastic surgery, again, Ron DiMatteo, who's our chair of surgery here for the Penn system, March 27th, to talk about not ramp down, but let's think ahead to ramp up. Are we going to have Saturday surgery? How are we going to do this? How are we going to address the backlog? And so we had a decision to support team that started by outlining our backlog in orthopedics. Who wants to come to the hospital? Which patients have told us we're going to wait on our disease? We don't feel good about coming back. And the way we've mitigated against that and ramped up and had a throughput percentage that has been healthy over the last couple of weeks. We started, if you will, elective surgery at May 4th, has been physicians. I've literally called personally my patients and said, I want to talk to you about your surgery. There's no pressure here, but it is a safe environment to come back. Here are the questions I'm sure you have. Everyone is tested. Here's how we're social distancing. Here's how the physician and healthcare workforce is going to care for you. Here's how our elevators are situated. Here's how our waiting rooms are situated for families. So these are collective lessons learned. Some have felt that the doctor-patient, the physician-patient, the surgeon-patient relationship has been eroded by either challenges in healthcare reimbursement, the electronic medical record, the role of insurance companies. All these things have been a sort of a cry of physicians that, you know, you've eroded the doctor-patient relationship by certain things. It's never been more true that the doctor-patient relationship, I think, has been what has allowed us to ramp up, to maintain trust as professionals and surgeons with our patients, and allowed them to come back safely, have good outcomes. In the darkest days, let me share the sunshine that's coming out. Penn Orthopaedics, we've worked like other orthopedic providers and actually surgical providers around the country to reduce length of stay, immediate therapy the day of a hip or knee replacement, decreasing length of stay therapy, and discharge to home to decrease costs. Can we discharge patients that have had hips and knees home? And we've made over the last 2 to 3 to 5 years at Penn Orthopaedics progress in these areas. The curves come down a little bit. We've been able to, when we started to operate again, using the MENS score, you know, the scoring system for morbidity, how many people will be required, how long is the operation, using the MENS score, recording every case for our public health officials and the health commissioner to be able to document we're doing ramp up safely. We've sent now 98% of our hips and knees home the next day or same day. That percentage was in maybe the 60s before COVID. Length of stay has come down 3/4 of a day, almost cut in half in terms of, you know, what we think of in terms of elective orthopedic care. And again, I'm using our typical hips and knee replacements. And while we had some issues for a variety of reasons, no fault of theirs, to get our physical therapists to see patients the same day as their hip and knee replacement. Parenthetically, a couple of years ago, I had my hip replaced. I was up walking 4 hours after my surgery, and I went home the next morning only because they wanted to keep me overnight. I could have gone home that afternoon. When I was an intern in 1982, patients would come in 2 or 3 days before their hip or knee for their workup. They'd have their hip or knee replacement done. They'd be in the hospital 10 days and then maybe go to a rehab facility. Now we're sending many patients home the same day. So again, pointing to what our own institution has done, having the ideal state and then being able to activate, these are some of the benefits. I wouldn't say benefits of COVID. We would never want to have a pandemic, but it just shows you how we can adapt and set new standards for ourselves that will continue commensurate with all the values of excellent patient care, safe patient care, measurable outcomes, acting on our data, and revising how we care for patients. We've been able to do that during COVID. Before I get on the phone, usually telemedicine, so I'm looking at the patient if we can face to face. Penn has done a great job at sort of preparing remarks, standard remarks. You're going to be tested. We maintain social distancing. But some of the questions, to your point, what are the questions that patients are asking, really center around the day of surgery. Who can come with me? And our health system initially, and we've changed this, really had sort of drop off of the curve, come in, get your surgery, somebody will pick you up. Then we went to one person can accompany you, obviously because of the need of social distancing. And now we're being a little more liberal about who can accompany the patient to the hospital. So clearly that's, as everybody can imagine, a big parameter. If your loved one can't be with you and wait for you, there's not only a family dynamic, but one would feel very much alone. So we have spent a lot of time assuring our patients that they can get the support of their family or their significant others to be with them. Number two, we maintain all the things that the American public has heard about relative to social distancing, masks for our employees and our healthcare workforce, gloves. And again, it's also a delicate balance. If the surgeon, and we never did this across our system, I'm sure my colleagues haven't done it either, it's what I'd call a soft call. You don't want to ever pressure a patient into coming into the hospital. I think what we've done is say, we're open again for business. We're here. Here's why we're safe. Here's why it's okay for you to come. If you feel comfortable, we're going to do everything we can to provide for you and your family. And your obligation, Mr. or Mrs. Patient, is to undergo testing so that we can assure that you're COVID negative and that you wouldn't, if you will, put our healthcare workforce at risk. We're going to need to coexist with COVID for a long time. And so that provides certain challenges. Again, we have capped out the amount of patients any one orthopedic provider can see on a day, 20 patients. We have, with appropriate staffing and help, we have some people seeing 70 or 80 patients a day. Now, these are quick, well patient visits, if you will, spending time and appropriate physical exam and documentation. I don't have to tell my colleagues that that's important, but like many surgical services around the country, there are those that require a very high throughput of patients to see enough patients with enough pathology to schedule patients for surgery. And if we just look at a conversion rate, if you're used to seeing 60 patients and you can only see 20, what is the surgical volume going to be on your conversion rate? And I think my surgical colleagues and others listening to this understand this. That's all the more reason why telemedicine and perhaps extended hours or opening up hours that we haven't done yet, but we're talking about opening a Saturday morning clinic. See, if I can only see 100 patients Monday through Friday, 20 a day, let's just say. Well, I operate some days. So let's say I see 60 patients a week. And I'm used to seeing 80. What about Saturday surgery? Saturday surgery and Saturday clinic. So we're going to develop some new strategies that will be in response to perhaps what we see in terms of the patient flow, not only in our clinics, but in our operating rooms. When you see a patient, they're putting trust in you. I mean, we can say this about the doctor-patient relationship because what comes out of your mouth, how you treat them, how you engage them, you're building trust. You're creating a relationship. And speaking personally, you can understand a person pretty quickly with a few basic questions. I always start by asking a patient, what kind of work do you do? Not why are you here to see me? What's your orthopedic or plastic surgery problem? Because, I do both. What kind of work do you do? Where are you from? What part of this city or country are you from? And so you establish a personal relationship with appropriate social boundaries, but trust is really important. And if patients come away from trusting their surgeon, and I have you scheduled for surgery in 6 weeks, and then COVID hits, when I call you back, you're going to have some degree of trust that's why you came to see me. That's why you've decided to have me do your workup and maybe schedule you for care. A lot of patients in orthopedic surgery and reconstructive surgery, you don't see them one day and operate them on the next. You may employ a whole series of conservative treatments, physical therapy, medications, things, and it's only after conservative measures may fail that you'd say, okay, well, we can't treat this problem conservatively. We have to operate on you. That's a series of visits and building trust. So I think the answer is we've built trust with our patients. We have to rely on that trust and not take that for granted. Any decision regarding a patient to undergo, and I don't say to a patient, I'm telling you you need this, or you will have this. What I usually say in my words are, I'm offering you this procedure. I never say to a patient, you need this operation. I mean, with rare exception, if it's a potential horrible urgent morbidity, ma'am, you need, or sir, you need to have this done, or else this is going to happen. I think the principle of shared decision making is what you're talking about, and that hasn't changed pre-COVID or post-COVID. It's a shared decision. I'm offering you therapy. I'm calling you up. We delayed your surgery because we had the citizens of your community that we needed to prepare for a surge. Our focus was on saving lives. Most patients understand that, saving lives. Now, Mr. Jones, we have enough PPE. We know that we can put you through our system safely. You will be tested to know that you don't have COVID. Some centers are even doing post-surgery testing 2 weeks later to make sure there's been no conversion. So I think that pre-COVID, post-COVID, to maintain the principles of good communication, shared decision-making, developing trust, being ethical, and being sensitive to a patient's desires, giving patients adequate time. It's the principle of that we teach our residents. Before you leave a room, you say to a patient, now, do you have any more questions about what I explained to you? Sometimes if I perceive a patient's not understanding, I'll actually say, now, can you explain back to me in a nice way? Now, what did you hear me say? I'm not giving you a test, but what did you, how have you heard what I've told you about the procedure I'm going to do? What additional questions do you have, and so forth? We just translate that philosophy to COVID. Your family can't come? Why? Well, because we're concerned about, disease transmission, or we don't have enough PPE, or our staff is redeployed. We want to engage our patients and answer questions. That's a fundamental part of being a surgeon, being a physician.